let's talk about how you can do a rheumatologic examination of the hands. So before starting the real exam, you have to maintain the 3 P's. What are the 3 P's? First, take permission, then proper position, and then proper exposure. Permission, position, and proper exposure. So what is the position? The patient should be in a seated position, and the patient should have a pillow over the lap, and you place your fingers over that pillow. So sitting, pillow, place fingers over the pillow. And then proper exposure. If the patient is taking, if the patient is wearing a shirt, they should take off the shirt, and you have to properly expose the upper limb, at least up to the mid-arm. But better to take off the cloth that they have, especially in a male person. If it's a female, then expose up to mid-arm. So after those, you have to follow the sequence of look, feel, move, and then neurologic assessment. So what are the things you see in the look? So the mnemonic for things in look is sword. You can remember the sword. Swelling, so S, W is wasting, and then deformity. Swelling, wasting. So some things are swollen, big, and some are small, we wasted, and then deformities. So where you look for swelling? You can start from the proximal area. There can be swelling in the wrist joint. There can be swelling in the metacarpophalangeal joint, proximal interphalangeal joint, distal interphalangeal joint, and also the joints in the thumb. So those are the areas to look for swelling. And there can be wasting. There can be wasting in the dorsum. So there can be dorsal guttering, or there can be wasting in the thinner area. There can be wasting in the hypothinner area. So that is swelling and then wasting. And then comes the most important part, which is deformity. So swelling and deformity both are very important for diagnosis. So what are the deformities you can see? So the deformities can be seen in multiple fingers. So if it's your thumb, a thumb may have a Z deformity like this. So this is the Z deformity where you have extension at the metacarpophalangeal joint and flexion at the interphalangeal. This is the Z deformity. And then comes the swan neck deformity. Swan neck deformity is just like this, where you have extension at the PIP and flexion at the DIP. Extension at the PIP, so the PIP is here, this is extended, and the DIP is flexed. This is a swan neck deformity. Then you can see the Batonia deformity, where you have the deformity like this. There is flexion at PIP and extension at DIP. This is the Batonia deformity. And when you place the fingers, there will be ulnar deviation, especially in a patient with rheumatoid arthritis. All of those findings that I've mentioned before are findings of rheumatoid arthritis. In patients with rheumatoid arthritis, there will be ulnar deviation of the hand. So those are the deformities that you need to look for. And you can have other important areas of inspection, such as you can inspect the nails. So what there can be in nails? In nails, you will find features of psoriasis, where you can have pitting, you can have onycholysis, or subungual hyperkeratosis. You can have features of dermatomyositis, which is periungual capillaries, dilated capillaries here, right here, or you can have Gottron papules, which are scaly erythematous rashes in the dorsal surfaces, over the PAP, over the MCP joints. So you can have those lesions as well. So those are areas of inspection, the most important areas of inspection. Now comes palpation. So before starting palpation, we have to ask the patient if there is in pain, and we should palpate very gently. So the first thing we do, we palpate for temperature, and we compare the temperature in the joints with normal joints. So we compare it. We compare normal, abnormal, normal. So this is the abnormal one, this is the normal one, and this is the abnormal one. So we have to compare the abnormal with the normal. And after comparison, we have to start feeling. So how we should feel? We can start from distal and we can come proximally. So you can compress over the wrist joint, we can look at the patient's face, and then compress over the metacarpophalangeal joint, then compress over the interphalangeal joint. And after the compression, general compression, we can specifically compress over the interphalangeal joints one by one, and same for the other hand. And after those, we can palpate the radial pulse, and we look over the extensor surface for any rheumatoid nodules. So those are the things that you have to do in field. Then comes movement. So for movement, just ask the patient to grab your hand like this. So this tests the movement of the flexion movement. Then ask the patient to release their fingers like this. So do this and this and this. So those are the common movements, and you can also check the abduction, adduction, and flexion, extension separately. But these two movements, like grabbing your hand and releasing their fingers, assesses the most important movements of the fingers. Then you can do the prayer sign. This is the prayer sign where you can see the extension of the wrist. Then you can do the reverse prayer sign where you can see the flexion or palmar flexion of the wrist joint. So those are the classic movements that you do. Then if you have something to give the patient, like a pen, so ask the patient to take the pen from their lap and write something. This is for functional assessment. And you can also ask them to unbutton their buttons. So like I am doing, unbutton their button. This is for functional assessment. Then you have to check for some neurological involvement, like the patients with RA often may have median nerve compression, which is the carpal tunnel syndrome. For that, you have to tap over the nerve, which is the Tinel sign, and this is the phalanx sign, where you have to keep the arms like this for like 1 minute, and the patient will have tingling and numbness in the median nerve distribution. And after those motor tests, you also have to check the sensory. And for sensory, you go through the dermatome. What are the dermatomes? You can start from like the C6. This is C6. This is the C7. This is C6, 7, C8, and you can go up to T1. But I think C6, 7, 8 are the most important ones. And overall, after the examination is complete, you would also like to examine the lower limbs, and you also like to examine the back of the patient. So those are the things that you might say that I would also like to examine those areas. And obviously you have to do you need to do a general exam after this musculoskeletal exam. So that's all. This is our examination of hand, and I am hoping that I will be able to find a patient, a classic patient, where I will do the test again. So this is a general overview, and I'll also do it in a real patients.